Thank you, Kai. Glad to be here to have a chance to talk about machine learning in healthcare. Today I will be talking about some challenges that we have with machine learning and artificial intelligence, and also some of the opportunities that we have based on these new technology. I have no financial conflict of interest here, so let's go to the next slide. If it was a couple of years ago, actually more like 10 or 15 years ago, probably I would have to give you a couple of examples to convince you that there are lots of applications of AI in the healthcare and that it has quite some potential. But not so much these days. You even don't have to go to PubMed to find out about those. If you just look at your popular news feed, then you will see many examples. And here I have a couple of such examples for you. Most of them are picked just from a couple of months ago, 2019. And you can see, for example, machine learning for drug discovery, for modeling transcription factors. There was a recent application for personalizing diet based on AI, and also numerous applications of deep learning for modeling at the cellular level. Many of them published at prestigious journals, Cell, Nature, Science. And of course, many tech giants are rushing to the intersection of healthcare with AI. For example, Google Healthcare, DeepMind, and many of the other companies, they are working on this. And no wonder, they are also at the cover of Science, Nature Medicine. And of course, there are also even entire books that are dedicated, like the Eric Toppel's Deep Medicine. So hopefully, I don't have to convince you about the applications of AI anymore. One thing that I want to talk about, though, is the terminology surrounding AI, machine learning, and deep learning, because sometimes there seems to be some confusion about this terminology. Here, in this picture, you can see that a little bit more clearly. You can see that AI is the superfield, and then we have machine learning, which is a subfield of artificial intelligence. And then deep learning techniques, which are a special type of machine learning technique. And machine learning tasks themselves also can be categorized in a couple of different ways. The most common one is to categorize based on whether you have any labeled data set or not. If you have labeled data set, for example, if every pathology image is labeled with cancerous versus non-cancerous, that is labeled, which we can use as a supervision signal to train these models. So we would call them supervised learning, unsupervised learning, where we don't have a labeled data set, and then reinforcement learning, which is another type of learning where it is more suited to interventions and where you have actions. There are many different types of machine learning models, and possibly you already have seen some of the conventional types of machine learning models, such as decision trees. They go back a long time ago. Support vector machines, and then, of course, neural networks, which have come back in various forms these days. Another terminology difference that I want to point to is the difference between what we call as shallow versus deep learning. Shallow models, which are more like the conventional type of machine learning models, with these models, typically, you cannot handle and analyze complex types of data, for example, like images, video, or text, clinical notes. But deep learning models, they can do that, and that's why they have become so popular in recent years. And one of the reasons that shallow models have difficulty is that because they have to build features from data, somebody has to tell the model what are some of the features, variables that are associated with each specific type of data. And with structured data, like electronic health record data, it's easy. Each column can be one feature. But when you're looking at images, what would be a feature? Some people were working on, for example, looking at edges of different orientation as basic visual primitives, but it's not that easy and it can be quite domain specific. So deep learning techniques address that problem by deriving those features in an automatic manner. And that's why they have become so popular for analyzing complex types of data. And most of the time, they are in form of neural networks that you see here, interconnected set of neurons. And at the initial layers, typically you have more basic representation. If you're talking about images, it would be representations of edges of various orientations. And then as you go on through the layers, the representation becomes more and more complex. For example, connection of two edges becomes a corner, and then later on, maybe you will have part of a nose or eye if you are recognizing a face. Another thing that I want to mention is that neural networks, they are not new. If you look at this figure, you can see that they go back actually to 40s, and they have come back in various forms, and we have had several AI winters throughout these years, but finally in 2010, we had the deep learning models. And there are lots of different types of deep learning models. For example, if you have images, the most popular tool for that would be convolutional neural networks, or CNNs. If you have temporal type of data or sequential type of data, recurrent neural networks would be a very good choice, though that is also changing. And also there are other types of deep learning models that can be used. Now, after giving this brief introduction to machine learning and deep learning, I want to also introduce two use cases, not specific to anesthesia, but more in the critical care setting and the ICU setting. In one of the first applications, my group was looking at if we can predict a real-time acuity score for patients after they are admitted to the ICU, and that can have many applications. And of course, there are conventional types of acuity scores, such as the SOFA score that has been used for years. But our purpose was that can we develop something that is not just administered once, like SOFA? It's administered just once every 24 hours. And it doesn't use all of the continuous data, all of the fluctuation in data. It only looks at the worst measurements. So to address that, we are using recurrent neural network because this is a time series of physiological signals. We are taking in all of the physiological signals, and we use that to build a real-time continuous acuity score of the patients in real time to be able to see how they are doing in real time. And here you can see some of the results. For example, this is one example patient. And initially, at the very first hours, bedside SOFA predicts about 5% chance of mortality, but using our technique, it is close to 80%. And as the time passes by, again, before the final hours of the patient, the bedside SOFA is around 51% mortality risk, but our model is predicting about 99.6. And the AUCs are also, in our case, are more close to 90+%, and then with the bedside SOFA, it is close to 74 range. And here you can see also some of the screenshots of that. Another one that I want to just briefly mention is that we can also collect other types of data that are not conventionally collected. Already we collect lots of data, but there are still some types of data that are not collected in a very efficient manner, such as nurse assessment of pain, especially in nonverbal patients, or function assessment. So in this project, we are trying to collect data using wearable sensors, cameras, noise sensors, light sensors, and based on that, we have collected lots of data in intensive care units and surgical intensive care units. And we have been able to recognize, for example, patient activity in an automated manner, as well as facial action units related, for example, to pain. Now, I have talked a lot about those applications and also machine learning in general, but at the same time, we need to recognize that there is, of course, lots of hype surrounding this topic these days, and a good example of that probably would be IBM Watson, if you're familiar with that one. In many cases, the applications that we see, They just rely on some sort of internal validation. There is no external validation. So we have to be very careful when we are reading these papers. And beyond that, there are just a couple of papers that I have seen that they are using AI for diagnostic purposes, and then they are also doing that in a prospective, multi-center, controlled trial manner. So we need more of these studies. Another problem that can be especially important in the future is adversarial attacks. What you see here is an example of a benign mole, and what you see here is a carefully designed perturbation that is added to that image. Now, this is after that being added. You don't see any changes visually, but the diagnosis of the model changes from benign to malignant. And you can imagine also vice versa. The same thing happens, for example, by doing simple rotations for some of these deep neural network models. They are kind of vulnerable to these type of attacks. With clinical nodes, if you are changing a subset of keywords, again, the same thing can happen. So these are some of the issues that need to be addressed before we rush to using such models in the healthcare domain. Another thing is bias. Probably you have seen this one, which is related to facial recognition based on skin tone, which works very well for white and especially male adults, but doesn't work so well for minorities. Now imagine if such a thing is used also for skin lesion detection or in dermatology. That's going to have some implication for sure. And of course, empathy, because we don't want to replace humans with machines. That can be also a very important concept here. One other thing that I want to point out to is many times we are talking about man versus machine, and also the hype is telling us that in the near future, the machines are going to replace doctors and humans. This is based on the figure that you see, is based on a recent paper by Eric Topol, 2019, and he brings up a couple of very good examples that this is not going to be possible in the future, at least in the very near future, that's not going to be possible. And if you look at, for example, automotive also industry, autonomous vehicles, if you talk to anybody that is working in that industry, they will tell you that while we will have more autonomous vehicles, there is a good chance that level 5, which is fully autonomous, we will not see that because of many of the ambient conditions on the road. The same thing happens also in the healthcare. We will have various grades of automation, probably level 3 and 4 more automation, but there won't be full automation. It's just not going to happen. And instead, what is going to happen is that AI is going to augment the decision-making process of humans, and doctors, nurses, make the job easier for them. And of course, in the future, if you are going forward, we need better validation models. As I pointed out, internal validation is not going to be just enough. We need external validation. We need prospective validation. We need multi-center validation. And stakeholders need to work with each other on FDA regulations, because we are talking about very sophisticated, very complicated concepts that sometimes, because these models are black boxes, we fully don't understand them. What are some of their implications? And the final thing that I want to bring up is regarding the human workforce. Most of us are already working in interdisciplinary settings, and we are working on writing grants in interdisciplinary manners. But the human workforce of the future also needs to be trained in that manner. Whether medical students need to be trained in AI, some computer scientists need to be trained in other domain knowledge, and of course humanities, those studying humanities and other areas, they also need to be involved. Human factors can be very important, because there will be lots of issues related to ethical and legal concepts of AI that hopefully, as the technology progresses, we also have to address those.